Okay, well, it's just gone 12:30. Welcome, everybody, to this week's report out. So we've got a couple of presentations to get through today. So we will do those in the usual way of hearing from both sets of colleagues, and then we'll save our questions and answers till the end. So I can see that Jay Palan, I can see you, Jay. Hi.
Hi, Phil. You're right.
Nice to see you. Yep. And is Nick with you?
No, Nick can't make it today, but we've worked together on this.
Yeah. Okay.
90-day report out.
Great. So can we come to you then? Thanks, Jay.
No worries. Thanks, everyone. Hi, everyone. So this is the 90-day report out from the Rapid Process Improvement Workshop. So essentially, as we're aware, the hip fracture service has been challenging to try and deliver best care for our patients who are presenting with hip fractures. So this bit of work was undertaken, sponsored by Gareth and Joe Adorinto, helped enormously by Jimmy and Rachel. So this is the 90-day report now on a few of the key objectives from that initial process. We know that, sadly, as an organisation, we could be doing better with our best practice tariff in terms of meeting the criteria for hip fractures, and in particular getting patients into theatre in time within 36 hours. And this has a big impact on the clinical outcomes of patients, because the longer patients are delayed in surgery, the worse they. This was our July best practice tariff, and you can see there that we are struggling to meet it. It was about 31%. And indeed, in August, in that week, 19th to 25th, we were 0%, and 0% of patients that week were operated within 36 hours, and the mean time to surgery was actually 72 hours. And this clearly has repercussions for, most importantly, our patients, but also from a trust financial perspective. There is money that is associated with the best practice tariff, and we are hemorrhaging that potential revenue for the BPT. So some of the things that we identified at the very start of this process, we felt were relatively low-lying fruits. So one of the things, and we spent a lot of time talking to all stakeholders, from junior doctors and nurses, everyone really, and that was really good. And we have looked at completing the hip fracture pro forma, clerking in the quality and completeness of that. And that is improved, as you can see there. So 90-day, we're doing 82%. Where the other thing that we've done well on is we've moved from paper forms, which I think is a massive improvement, to the electronic clerking on PPM, and that's 100% compliance. Where we are struggling is our start time for theatre, i.e. the number of patients in the anaesthetic room at or before 8:30. You can see that the 90-day report was only 20% for that week's audit. Where starting on time isn't great, only 60%. We had this idea of a good-to-go patient, previously known as the golden patient, who had been identified and worked up and planned, and everything was sorted out so that they weren't being cancelled on the day of surgery or the list being changed, and that was 80%. But as you can see here, we're not achieving our target of getting the patients to surgery from the time of admission within 36 hours. And morale was pretty poor amongst many colleagues across all allied healthcare professionals and nurses and doctors. So we've also undertaken a junior doctor 90-day survey, and the current crop were a bit more positive, and a big part of it is down to the work done by Nick Freeman and Vidya Nair, who've really populated the Padlet in terms of giving a huge amount of information for our junior colleagues when it comes to clerking in patients, having standardized protocols on what to do, etc. And I think this has been a really positive experience for our colleagues. And as you can see here, morale was a bit better. They're very keen on the Padlet and as a way of transferring information, And again, most people feel that using electronic clerking was the way forward. So that's a positive. I would put a plea here, and I know that Padlet we're going through an issue about Padlet and information governance. There are no patient records on Padlet. It is purely just protocols and information on the things that are needed to clerk a patient in properly. We would plead that Padlet is a really good way, with a QR code being sent to all junior doctors, a really good way of using that information. Next slide, please. And then in terms of the staff survey, you can see here, there's really frustrating when the first patient has to be changed, or because there's issues with kit and instruments, and that slows things down. Often investigations still aren't complete, and the list remains inefficient due to many factors, and I'll come on to that. We also looked very carefully at portering time, which seemed excessively long, and I'll come back to that as well. And at the moment, we still really can only achieve 3 hip fracture cases a day, and that hasn't changed. So what are the key learning points? Well, I've talked about the 100% electronic record keeping, and we are getting better at completing the NOF pro forma, and Padlet and repeated education for our colleagues is important to make sure that this is done and that the checklist is done and checked. There are a number of barriers. Standards are slipping. We were doing well at 60 days in terms of team briefing, good to go patient start time, and that has slipped. And there are reasons for that. Staff morale and engagement remains challenging. Portering issues are currently being in the trial process to being addressed, which is positive. Ward checks are still not as complete as we would like, which then slows things down and affects portering. It has not had any impact on best practice tariff, and we're still not achieving 100% checklist on our hip fracture pro forma, and we're still only doing 3 cases a list. And most importantly, I think as part of all of that, we are dealing with greater and greater complexity of cases, revision, hip and knee replacements for fracture or infection, which are emergencies that basically interrupt the flow of our bread and butter cases on hip fracture lists. And I'll go into more detail. So we need to really tackle the core issues at the heart of all of this. This tells you I audited in a 2-week period on the 22nd of July, all of our complex cases that suddenly came in, and you can see there were 15 cases of fractures and infections, all of which require specialists. I'm a hip and knee surgeon, and my colleagues and take 3 to 4 hours sometimes to manage, and they go onto the hip fracture list. Now, one of these cases takes out 2 standard, and I say standard in inverted commas, hip fracture patients. And yet you can't leave these cases because they are as much emergencies as a hip fracture patient, if not more so. So this is the challenge we have. How do we separate out managing these group of complex patients, and the numbers will grow because we're doing more and more hip and knee replacements generally, versus our sort of hip fracture population. So what's our next steps? Well, we've now initiated gathering more data, and one of our orthogeriatrician staff grades, Mamoon, is now tasked with doing regular data audits as part of his job plan in terms of 1 week in theatre. He will also do a week of looking at the hip fracture pro formas and also the electronic discharges to give us that data to see whether we are getting better at completing the checklist and things like that. One of the things we haven't done is instigate a patient survey side. We've done staff survey. I think it would be really useful to get patient and their relatives' feedback on how they view things. This is courtesy of Lee Parker, our general manager and TRS. I'm grateful. So a number of things have been taken on board, and these are some of the things that we're looking at to try and improve our checklists. Registrars will ensure marking the site. Bloods are done appropriately. The ward team will double check all of these things, and then before the day of surgery on the fight, there will be a final ward check. And then the hip fracture service with Julie and Adam will continue to educate and support us in this endeavour. The Padlet links are there also, so this is all sent to our junior colleagues as well. So from next week onwards, Lee and some of the team have started an initiative to try and improve certain things And extended anaesthetic cover is being discussed. I've put here in red that there has been some pushback from colleagues, as one can imagine, because of the extended working time, and clearly that job planning is a challenge. Using PACU for early patient transfer so that there's a place for patients to wait before coming to theatre, that's good. Having a named porter for Theatre 15 will hopefully help reduce the downtime waiting for portering services, and hopefully that will be a very positive step forward, and then escalating any issues to the operational matron as and when. We will be looking very closely at the productivity of Theatre 15 and looking at why there are delays for patients on the ward before coming down to theatre. So it is clear that there's a lot of interest and effort being put into this aspect of what we're doing. My feeling, and that of Nick, and shared by many others, is that if you really want to change our position for this group of patients, hip fractures, sadly, we're towards the bottom end of the National Hip Fracture Database in terms of BPT, and we want to be in the top 5. I think you have to have a dedicated hip fracture team. This is how other units, and I've been in touch with colleagues in other places where they do have a dedicated hip fracture team, and there's a surgeon who has a very specialist interest in delivering hip fracture care, supported greatly by middle grade staff. One of the main issues we've had is that we have lacked senior surgeons. We're dependent on registrars often, who are a mixed bag in terms of experience, and therefore lists are often going on where they don't have a senior surgeon, or we have to move things around, which inevitably changes the flow of theatre. If you had a core group of surgeons who could deliver hip fracture service day in, day out, certainly 5 days a week, supported by staff grade or associate specialists, and indeed have a fellowship for new surgeons coming on who have an interest in this, I think that would be very positive. We already have orthogeriatrician support, which is great. Anesthetic cover, you want a core group of anaesthetists who have an interest in managing these patients. These patients are usually anesthetically complex as well as surgically, and we know we have a group of anaesthetists who would be interested in managing and taking on this challenge. Having a core group without a whole range of different colleagues doing this means that you reduce variability in practice. One person cancelling a patient for needing this and that is not necessarily what other anaesthetists may do, and reducing that variation would help. I personally think that A&E, because of the sheer busyness of A&E, sometimes struggle to get all the necessary basics that we need from A&E, and that delays not only the patient coming up to the ward, but when they get to the ward, certain things aren't done. And personally, I think we need to help, and I would have a HIP team, and you extend the roles of the trauma nurse practitioners, and you expand the roles of Julie and Adam, and have more such colleagues who can see the patients directly with the on-call SHO directly as soon as the Yorkshire Ambulance Service brings that patient in and they've had a confirmed hip fracture. We take the worry of A&E having to do all of that, and we take control of this, and that patient's then shepherded to the ward, knowing that we've got all the basics done. The other big thing is that split list theatre lists are inefficient. And if you had all-day lists with the same surgeon, same anaesthetist for an all-day theatre as we do on weekends, then I think you would see a real improvement, and flow would be better. You only brief once, it's the same team, and you aim for 4 cases a day as a minimum, and you reduce the downtime between cases. As soon as you break for lunch because a new team comes, you inevitably bring in a 1 to 2 hour delay. And the final thing is capacity to then do the other complex cases I've alluded to. Those cases need to be separated out from hip fracture cases, the analogy being high volume, low complexity cases in hip and knee replacements versus revision surgery. Trying to do both on one list inevitably makes it less efficient.
That's great. Thanks, Jay. I think it's really helpful, because I think it's good to recognise that sometimes a lot of learning comes out of applying the method and understanding where we are, rather than necessarily just reporting that something's had an impact. So I think great presentation. I'm sure there'll be lots of questions about this, but we will move on and take questions at the end. So can we? Thanks again, Jay. Can we come to Abigail and Rebecca, who I think you're in the same room by the look of it? Is that right?
Yes, thank you. Hi everyone, we are part of the Remote Monitoring Virtual Ward, and we're just aiming to achieve providing an alternative to admission or facilitating early discharge for patients. We've been running since September 2023, and we've now managed to build up quite a few different pathways throughout the trust.
So hi, my name's Rebecca. I'm one of the sixes on the virtual ward. So just to give you an overview of the kind of pathways that we have developed since starting, we do work across sites. So we take on patients at St James's, LGI and Chapel Allerton. You can see our biggest sort of intake of patients is general surgery at the moment. So we have GSM, general surgical monitoring, ERCP patients awaiting an ERCP date and slot, hot gallbladder patients awaiting lap choles, and pancreatitis patients. In terms of other sort of CSUs and departments, we've got one neuroscience pathway for patients following sort of simple spinal surgery. We've got a vascular pathway in terms of ischemia, a respiratory and oncology pathway as well. And then finally, we have a cardiology pathway, which is mainly based in LGI, where we take on patients who are awaiting sort of TAVI investigations and procedures. And we've recently started working with the research team to take on STEMI patients and monitoring patients who have had a MI within the last sort of 24 hours, getting them home earlier and monitoring them for a set period of time. So this is just some examples of sort of the nursing tasks that we do on the virtual ward. So obviously, while our patients are at home, we are sort of the main point of contact for escalation, any concerns, any clarifications. So while our patients are at home, the number of days that they are on the virtual ward is supposed to reflect the number of days they would otherwise be in an inpatient bed. And we monitor them at home, book any necessary appointments, whether it's pre or post-surgical bloods, USSs, echoes, CTs, and we work with the medical team where needed to facilitate this. We also work at helping to ensure the patient can get to and from these appointments. We can, like I say, we can do bloods for before and after. And for patients such as the ERCP patients, hot gallbladder patients in general surgery, we arrange for them to sort of they work behind TCI and getting them on the bed list, making sure they have a slot and a bed available, and that the bed managers and admission units, whether it's David Beavers or JAL, are aware of these patients.
So this is just showing our success to date, and we've been running nearly a year now. We've got multiple pathways, as Rebecca said, throughout the trust. We've managed to help 358 patients, saving just over 1,900 bed days now, and our average length of stay is around 5 to 6 days. We just look at acutely unwell patients that we can assist and help get out of hospital earlier with remote monitoring. And this is just assisting with the flow of patients, as well as assisting with admission avoidance.
So this is just an insight into our process and sort of how a patient joins the virtual ward and what happens once they have. So our referrals are sent by medical teams. These can be ACPs, regs, doctors, anyone who has reviewed the patient and has interacted with the patient. We receive a referral on PPM, which can be done through specialist referrals and typing in remote, and we come up as the remote monitoring virtual ward. We vet these referrals, and if accepted, we go and see the patient. Each SOP and pathway has their own inclusion and exclusion criteria. so that we can ensure that the patients are safe to be monitored at home, and that where appropriate they can use the device and they have a next of kin nearby, just to ensure sort of maximum safety when they go home on the virtual ward. And we do need to see patients once they've been referred. We need to see them before they leave hospital in order to introduce ourselves, get a consent form signed, show them the kit, etc. We meet them, go through all of this, answer any questions. The patient is then discharged from the wards and discharged home, and that's when our period of remote monitoring starts. Often the details for this remote monitoring for each specific patient is usually found in the referral, past medical history, and the standard operating procedure that we follow. And we are made aware of any repeat bloods or investigation or appointments that are upcoming that the patient will need to attend. Eventually, the period of monitoring ends. This varies greatly by a pathway. Sometimes patients are just deemed medically fit, sometimes they come in for the planned procedure, but we often have a range of discharge options, whether it's nurse-led discharge, if someone's improving clinically, or whether someone's admitted for their procedure. The period of monitoring then ends and the patient is discharged from the virtual ward, and we have no further input. So just a bit of an overview of the devices that we actually give out. So as I mentioned, we have some cardiology pathways. So patients who are often awaiting a TAVI procedure do not do any observations, and instead we just do a daily phone call. The STEMI patients, part of the research trial, dictates that they only do a blood pressure and a heart rate twice a day. Everyone else on all other pathways goes home with these MicroLife devices you can see on the screen. This includes a blood pressure machine, a finger probe, and a thermometer, and patients submit these observations to us usually twice a day, and we use our own triaging system, which we will talk about more in a moment, but similarly to the news score that we use in hospital, we are alerted if any of those readings are then out of range, and we then take the necessary steps, which are usually contact the patient, check they're okay, ask for a repeat reading, and take it from there. Next slide, please.
So this is the software that we use. It's in healthcare, and we developed this system bespoke to us. So we developed this within healthcare to make sure that it meets the needs that we want the patients to be able to send the observations through and clearly see any alerts or things we need to contact them. This is set up ideally bespoke for each pathway, so it's set up with the clinicians as well. They helped us to develop these and make sure we're identifying the correct things that we need to see in case of any escalations.
And just at the end here, we've just included some patient feedback that we've had from patients who have been on the service. A lot of patients have found it really valuable to go home and either recover or wait for their procedure at home. We found particularly oncology patients, because they're constantly coming in and out of hospital and often have lots of clinic appointments or are presenting to Jonah. We found that they've been really keen to get themselves home and sort of have that sort of relief and reassurance that there is always the nurse at the end of the phone, and that things can be escalated. We can help them with medications, test results, anything like that. And yeah, just to say thank you so much for having us.
Thank you.
Fantastic. Thank you very much, Abigail and Rebecca. Really good, and really such an important, again, really important part of our pathways, and actually, you know, in some ways great to see a little bit of dovetailing between the two areas that we've heard this the presentation this morning of patients. Okay, fantastic. So thank you both. We've got some time for questions. Anybody like to come in with a question or comment for either Jaya about the hip fracture pathway or remote monitoring? Maybe I could just start off then. Jaya, I was just wondering whether other comparable organisations have a team that you were talking about, because it strikes me that quite a lot of what's coming into us sounds quite complex, and are we actually set up for? It sounds like one of the benefits in a way of doing the work has to be the realization that we're actually dealing with not at all a straightforward patient population here.
Yes, thanks, Phil. So I think there are examples in other places where there's a dedicated hip fracture team. Where I trained in Leicester, Leicester was the second busiest hip fracture unit in the country. Does about 1,000 hip fractures a year, and they had a process where they trained a core group of trauma nurse practitioners who would go directly down to A&E to see patients from as soon as they arrived, to help shepherd those patients almost sort of through the process and then straight onto the ward without waiting around in A&E, because we know those patients need to be admitted anyway. So the less time they have to spend waiting for this, that. So it sort of helped bypass the normal process to get these patients their analgesia, their blocks, make sure, and that seemed to work very well. And so that's where I think some of the thought processes have come from my previous experiences. There are other units, such as the University Hospital North Midlands and Peterborough, where they have employed dedicated consultants who have a special interest in hip fractures, trauma and orthopedic consultants, who have really gone and taken the process and led with the team supporting them. And these are complex patients. You see the number of healthcare professionals who are involved in these patients' care, from not just surgery, anaesthetists, care of the elderly, but all the allied health professionals. And we've not even touched about discharging planning yet, and all of that. That's a whole different ball game. But we've been looking at this topic for years. I've been here now 5 years, even beforehand, and the worry is that we will touch around the sides and we can improve the low-hanging fruit, but we don't address maybe the core system, that we are a major trauma centre, so we deal with that complexity of patients, but we also have to deal with patients who come in with common hip fractures, and trying to square that hole is analogous to what we do in complex hip and knee replacement service, and we're a major revision centre, yet we still have to do our standard hip and knee replacements for patients. And until we find a way to separate out those two, I think what tends to happen is the more bog standard bread and butter stuff suffers, because we're dealing with other things.
Yeah, agreed.
And that's the challenge that we have.
Yeah. Thanks, Joe. Magnus?
Thanks, Phil. Joe, me and you will catch up afterwards. Thanks for that. It just feels like we're trying to put baskets and trolleys in the same aisle, and I think we could maybe simplify it in a way, to use a supermarket analogy.
Yeah.
Okay. Great.
Yeah.
Okay. Thanks, Magnus. Jimmy?
Thanks. I just want to put it in the chat, but I just want to acknowledge that I think there's a hugely helpful report out, Jay. I think there isn't any point coming to these forums and saying things are great when they're not. You guys have tried really hard with what's in your gift, and so I think this is a fantastic piece of work, because it's shining a light on the things that are really difficult. And some of that is within the gift of the team that are working on it. And I expect, and you have brought, this is what we're going after. We've not stopped. We're going after it. But this is also the right place to say that there might be some help needed. So yeah, thank you to you and the team. I know it's a team effort for just positioning it exactly as you have. I think that's our improvement method. We're not shying away from the tough stuff. So yeah, thank you. I did have a question, but I'm going to be quiet because we're a bit tight for time. Thanks.
All right. Thanks, Jimmy. Okay. I just for Abby and Rebecca, just wondered, obviously we're talking just about patients coming out of hospital. Do you have a sense of any involvement, or what's your sense of where the community colleagues are with some of the work you're doing, and also then the ones who are the idea of virtual wards, of course, was to help sometimes people not to need to come into hospital because of this as well. What's your sense of both of those?
Yeah, so we're working with, we're in line with PCAL now, so I'm now service manager for PCAL as well. So we're looking at patients or GPs who are ringing for their patients through to PCAL and seeing if we can amalgamate any pathways and pick up patients prior to them coming into hospital or directly from ED to help with the flow of patients through there. So we are looking at the step up from community, definitely, and the links we can do with LCH as well in the community.
Okay. And that's for this group that are coming out of hospital as well as the group that are avoiding coming into hospital. Do you feel you're working well with community around some of the hospital patients being discharged?
At the minute, our hospital patients that are discharged to us would have been in hospital. And when we discharge them, because of the pathways we have, community don't need to be involved.
Okay. Okay. All right. Okay. Okay. Is that something, do you think we need to explore in further kind of iterations of a kind of improvement approach?
Yeah, I think we're growing at the minute, and we're always trying to add new CSUs and to broaden our service. So definitely, you know, we're open to suggestions and to collaborating with community to assist and, you know, work together, definitely.
Yeah, great. Okay, fantastic. Thank you for that then. Dan? Well, you're just on mute there, Dan.
Sorry. Yeah, very quickly on that, Abigail. There's some work. I'm now medical director for partnerships and integration at the trust, and there is quite a bit of work going on in the community on tech-enabled care, and part of that is obviously virtual wards. I'll send you an email after this. Happy to discuss some of the work that's going on with the community. I think this also ties into Jaya's work around the sort of, you know, potential of decreasing some of that workload of hip fracture. It'd be interesting to see how much of that is preventable hip fracture. There's quite a lot of tech-enabled stuff that can be done to prevent any of these patients coming, well, some of these patients coming in the first place. So again, be interested to discuss some of that, some of the work that's going on regionally.
Great, yeah, thanks, Dan. Okay, I can't see anybody else wanting to come in. Jay, you want to just come back on that? Sorry, yeah. You're just on.
Sorry, I'm on mute there. Sorry, just on that. Thanks, Dan. We are trying. I'm clinical lead for WIAT for trauma and orthopedics now. So one of the things that is on the agenda for that is to look at how hip fracture services delivered in West Yorkshire. Some of the other trusts in West Yorkshire have transformed how they've managed things, and part of the one stream from that T&O bit is to look and see whether we can learn how some of our colleagues in the other trusts in West Yorkshire through WIAT have achieved that. I'm not saying that we'll be able to necessarily copy and paste exactly, but that's the strength of where we are, is that we work very well with our other trusts closely, and absolutely I think there's a lot to be learned from shared experiences. We all face patients with hip fractures in West Yorkshire, so it's a common theme, and it's a common theme that many hospitals struggle with as well. So that is another avenue that we are going down.
Great. Okay, thanks for that, Joe. Well, we are over time, but that's been a good discussion, and actually it's been two really important presentations about our frail and vulnerable patients. So it's actually a really good set of conversations. Great work done, as others have said. You know, important to hear about the challenges as well as about the successes, because that gives us a focus for future work. So we'll stop there. Just thank you again, Jaya and Abigail and Rebecca, for two great presentations. Really good to see the work being done, the analysis and the understanding that's come from that. And we'll bring Report Out to a close. Thanks, everybody.
Thank you.
Thank you.